Okay, I'd like to welcome you to this episode of the podcast, and this is part of the obstetrics and gynecology revision series. And today, our guest is a 500 level medical student, in person of Najib, who is also known as Galileo. So here we'll be talking about postpartum hemorrhage, which is a very common obstetric emergency condition, and is kind of one of the major cause of maternal mortality. So I'd like to formally welcome you to the program.
Okay.
So now we'll start by I would like you to introduce what postpartum hemorrhage is.
All right. So postpartum hemorrhage, as it is defined, is a blood loss of more than 500 milliliters following the birth of a baby. That is the definition, quantitative definition, but the clinical definition is much more important than the quantitative definition, and that is any blood loss following delivery that adversely affects the general condition of the mother is referred to as postpartum hemorrhage. So it doesn't matter. The important thing in PPH is the effect of the blood loss rather than the quantity, because estimation of blood loss is most times inaccurate, especially the visual estimation, and during delivery or after delivery it is very, very difficult to quantitatively measure the amount of blood lost. So that is why the effect of the blood loss is much more important, and it depends on three things. So it depends on the pre-delivery hemoglobin level, then it depends on the level of pregnancy-induced hypervolemia, and then the speed by which the blood is lost. So that is postpartum hemorrhage in brief.
Okay, thank you very much for that brief and nice introduction into the topic. So now, as we all know, in the process of management, we follow a particular outline, and part of the outline, the next thing we'll be talking about, we'd like you to tell us is history. And history, we know it contains both the symptoms, the risk factors, and other things that can really pinpoint us to know that this is PPH. So I would like you to tell us more about the history with regards to postpartum hemorrhage.
Okay, so the first thing is that I'd like to say that postpartum hemorrhage is probably the most important cause of maternal death worldwide, and it has been there from time immemorial. So PPH, looking at it, PPH, we have to look at the risk factors. We have to look at the risk factors for PPH, but most cases of PPH, they occur without even an identifiable risk factor. Okay, but although we have risk factors, okay, for PPH, so some of the risk factors can include multiparity. That is one. There can be multiparity. There can be polyhydramnios, anything that will cause over distension of the uterus. Multiple gestation, polyhydramnios, mycosomia, antepartum hemorrhage, malformation of the uterus, uterine fibroid, and other things. There are some risk factors. Even advanced maternal age, obesity, a woman with a BMI of more than 35. These are also risk factors. Even anesthesia too, the depth of anesthesia and the anesthetic agent that is also used can also be a risk factor. And another important risk factor is a previous history. As the woman has a previous history of postpartum hemorrhage, so she's at a greater risk of having another one in subsequent pregnancies. So these are some of the risk factors that are associated with postpartum hemorrhage.
Okay. Now, thank you for giving us those risk factors. But we would like to know some of the symptoms. If there is an identifiable symptoms, are there any identifiable symptoms that we can use to?
Okay. So as we have said before, quantitative, the clinical definition is what is important. Okay. So whenever a woman following delivery, she starts to exhibit clinical signs and symptoms, then we will be able to recognize early and start the commencement of the appropriate therapy. So some of the things you see is a rise in heart rate, tachycardia. There can be an increase in respiratory rate. There can also be like I've said, there will be rise in heart rate, increase in respiratory rate, and other things too can also be.
Okay. Thank you very much. So thank you very much for that. Now, I would like you to kind of tell us some of the signs a doctor, in form of physical examination, some of the signs the doctor can pick up.
Okay, some of the signs you can notice: increase in the heart rate, decreased systolic blood pressure, increased respiratory rate. These are some of the things we can also see, and you can even see signs of dehydration. That will tell you maybe the patient is even going towards shock. You can also see all of these things.
Okay, thank you very much for that. Now, next is the diagnosis. As they say, diagnosis is how you'll be able to confirm this is what is happening. This is the particular condition happening. So we would like you to tell us, how can we diagnose exclusively that this is PPH?
Okay, as we know, postpartum hemorrhage is bleeding after delivery. Okay, any bleeding into or from the genital tract following the delivery of a baby is postpartum hemorrhage. Okay, by definition, a bleeding more than 500 milliliters of blood, that is postpartum hemorrhage. So any bleeding from the genital tract that is beyond normal, okay, will point to you that that she is having a postpartum hemorrhage.
Okay, so now you are trying to say that we use the quantification of the blood to be able to confirm that we have PPH, right?
Yes, we use the quantification of the blood, and then we also make a quick assessment of the hemodynamic status of the patient. So for a patient having increased heart rate that is rising above 100, 110, 120, respiratory rate is rising, for example, more by 30, or the blood pressure too is also falling. So these are pointers that the thing is getting worse and it is actually a postpartum hemorrhage.
So in short, diagnosing PPH is basically clinical. It's clinical.
It is clinical. Okay. Even if the blood loss is not up to 500 milliliters, as I've said earlier, the effect of blood loss is more important, than the quantitative estimation of visual estimation, because most of the time they are inaccurate, and physicians and even other healthcare practitioners, they often underestimate blood loss.
Okay, thank you very much for that. Now the next thing is, after diagnosing it, we do investigations for many reasons, like trying to know the extent of the disease, trying to know, see whether some complications have set in, and so and there are some baseline investigations too. So now, what are the investigations that we will want to do after setting in PPH?
First of all, I would like to say that postpartum hemorrhage is one of the most important emergencies. It's a life-threatening emergency. So what we do is we have to be able to recognize the condition early. Then we make communications. The most important thing is recognition and initiation of therapy to manage the condition. So the first thing we do, we take some immediate measures whenever we are able to recognize early that this woman is having postpartum hemorrhage. So what we do is we initiate some immediate measures. Then we will now go on for
our investigation.
Cause-specific measures. So one of the immediate measures that we take is, first of all, recognizing that the woman is having postpartum hemorrhage. Then we call for help. That is the communication. Now you call for help because it is a multidisciplinary approach and it is not a one-man job. So we call for help and we get as much help and as many hands as possible. So we call for help, that's the first thing, and then we commence two IV lines, wide bore cannulas, 14G. Then we start 2 liters of crystalloid, normal saline or Ringer's lactates.
Okay.
These are the things you do first. Then remember, you have to take a blood sample for complete blood count, for coagulation screen, including fibrinogen level, renal function test, liver function test, and importantly, blood grouping and cross-matching.
Okay.
So that is just what we do. Then we also make sure that we catheterize the woman. Police catheter has to be in place. This catheterization will serve 2 purposes. The first purpose of the catheterization is to remove, because this woman now, she has been in labor and maybe she hasn't really passed out urine in a long time. So we are trying to empty the bladder, because bladder itself, when bladder is filled up, it interferes with uterine contraction. So the first thing is we try to empty the bladder. Then the second, it can also help us monitor the urine output.
Okay.
Remember, if the woman is progressing is going to shock, as the shock is progressing, we expect the urine output to decrease. So catheterizing the patient will help us monitor the urine output in that instance. And then we of course have to make sure that we assess the hemodynamic status. We take our vitals, pulse rate, blood pressure. We even take the oxygen saturation. That should be done every 15 to 30 minutes, either by the medical students on call or the house officer, or any other person that is available at that moment. So these are the immediate measures that we take in postpartum hemorrhage.
Okay, so you are basically lump and give us both the treatment and the investigation, right? And so I don't know, is there any more things that we are expected to do with regards to the treatment?
Yeah, with regards to the treatment, this is just the immediate measures. Remember, in immediate measures, we have to do ABC of resuscitation: airway, breathing, and circulation. If the patient needs oxygen, we have to give oxygen 10 to 15 liters per minute. We check the breathing too, then circulation as we have discussed here. Then now, the other thing you do, then you try to look out for the cause of the postpartum hemorrhage, and then we take care of it promptly. So the postpartum hemorrhage, it can be caused by many things. Okay, it can be due to loss of uterine tone, uterine atonicity. It can be due to retained placenta. It can be due to trauma. Maybe there's a trauma to the genital tract, and it can be due to coagulopathies, uterine inversion, or any other causes too. So the other measure now, the subsequent measure we take now, is to identify the cause and then treat.
Yeah.
So identifying the cause, the first thing you do is to feel the uterus. Okay, so we feel the uterus. How do you feel the uterus? Is by palpating the fundus of the uterus. Abdominally, we palpate the fundus of the uterus and see, is the uterus flabby or is it well contracted? A flabby uterus will tell you that, okay, the most likely cause of postpartum hemorrhage is loss of uterine tone. That is atonic uterus. And that will tell you what to do. Okay, but when you find that the uterus is well contracted, then the most likely cause is trauma to the genital tract, and that will also tell you what to do subsequently. So for most causes of postpartum hemorrhage is due to loss of uterine tone. As I've said before, there are many risk factors. Anything that will cause over distension of uterus is a risk factor.
Okay.
Multigravida, polyhydramnios, microsomia, and other things too. So whenever you now realize that that the uterus is flabby, so there are some things you have to do. So which is the first thing you do when the uterus is flabby? Of course, now you have to give oxytocin. 10 to 20 units, 20 international units of oxytocin in 500 ml of normal saline. And of course, you have to massage the uterus by manual compression of the uterus. So your hand, one of your hand is in the uterus, and then the other hand is above the abdomen, and then you massage. Whereas then you continue giving the oxytocin, 10 to 20 international units of oxytocin at 40 drops per minute. So these are the measures now you take and see if the uterus can become hard, and then contraction can actually happen. Because it is important to realize that uterine contraction is much more important than clot formation or platelet aggregation in hemostasis in this condition.
Okay.
So the thing is that we are trying to make the uterus contract, because when the uterus contract, so it will lead to effective compression of the uterine sinuses that are torn. Remember, when the placenta separates, the uterine sinuses become torn, and that is the cause of that is where the bleeding comes from. So effective contraction of the uterus will lead to compression of these uterine sinuses, and the bleeding can be arrested. So these are just the things you will do. But now, if you have access and this thing is not working, then the next thing is you give another uterotonic. So you can give methyl igometrin. So methyl igometrin, you give it. Methyl igometrin it causes a very strong uterine contraction. So that one can also be given, whereas you will still continue observing. If it's not working, then you have to change something else again. So if that is not working, you give methyl igometrin 0.2 milligram intravenously, slow intravenous infusion. It can be given either IV or intramuscularly, but intramuscularly will take about 7 minutes before onset of action, whereas IV takes about 90 seconds. Then if that isn't working, if that is not working, then you can also give misoprostol, 1000 microgram of misoprostol rectally. You give it, and then you assess whether the uterus is contracting or not. If that is not working, you can give another prostaglandin analog, PGF2 alpha analog, which is carbaprost, can be given. 0.25 milligram of it can also be given, and then you see whether it is working or not. So these are measures basically that you take to confirm. These are things you do, that can help to stop the bleeding.
That is for a tonic
uterus. But if all these measures now that you have taken now is not working, then you will be considering other things like tamponade, balloon tamponade can be considered, or by manual compression too. You have to continue doing that, or maybe a tight intrauterine packing. But for intrauterine packing, we don't do that anymore. So we can go for balloon tamponade, and balloon tamponade is even considered the first line surgical intervention when the uterotonic drugs fail. So the first line surgical intervention is actually using a balloon tamponade. So for this, we use the Bakri balloon. It is specifically made for this purpose. So the Bakri balloon, so what you insert it into the uterus. It has a capacity of about 500 ml, so we inflate. Using the Foley's catheter, we inflate to about 300 to 500 ml. So the mechanism of action is that this balloon, not only does it stimulate uterine contraction, it also has the ability to exert hydrostatic pressure on the uterus and arrest the sites of bleeding.
Okay.
So that's just it. So after doing a balloon tamponade, we're using the bakery balloon, and if it is not working, or maybe sometimes this balloon it is not readily available, so you can use another one like the condom catheter. So if the tamponade is not working, then you'll be thinking of a surgical intervention now. So the surgical procedures, they can be by manual. The surgical procedures can be the uterine compression sutures or stepwise devascularization procedure.
Okay.
But the thing is, the stepwise devascularization procedures, they take more time. And remember, it's an emergency situation. The more the time we waste, the lesser the chances of survival. Remember, the uterine artery, if you look at the blood supply to the uterine artery, for a normal pregnant uterus, it is around 55 ml per minute. First trimester, it has increased 125. Second trimester, 500 ml. In the third trimester, about 1,000 milliliters of blood is flowing into the uterine artery per minute. That is, both uterine arteries. So you see, the more time you waste, the more time it takes to actually arrest the bleeding, the lesser the chances of survival. So that is why we first do uterine sutures first, uterine compression sutures first. Then if they don't work, then we have to go for stepwise devascularization procedures. So for the uterine compression sutures, we can do the Billings procedure. We can do we can use the Billings sutures, Heyman's sutures, and other ones too. Then if these ones did not work,
I haven't heard that Billings is the name of the person that found the procedure.
Yes, actually,
right?
yes. Then there is Heyman's suture too. If these don't work, then we try one of them, the Billings suture, and it did not work, then we go for stepwise devascularization procedures. So remember, we go step by step. We try and say, okay, let us devascularize the uterine artery itself. So we ligate the uterine artery, either bilateral ligation or unilateral ligation, as the case may be. So we ligate the uterine artery. If that is not working,
so if we ligate the uterine artery, what will be the source of blood supply to the uterus?
It's something that you do. The most important thing at that moment is to stop the bleeding. Okay. And that is why we are actually ligating at that moment. So if that doesn't stop the bleeding, then we go on and ligate the uterine and ovarian arterial anastomosis. So we try and ligate them, and in most cases, doing this will actually resolve the issue, and it will prevent you from doing other things like hysterectomy, which is actually the last resort. So if ligating the uterine and ovarian anastomosis is not working, then we might be thinking of, okay, now we have to ligate the anterior division of the internal iliac artery.
Yeah.
Remember, we can't ligate the common iliac artery because it gives a branch, external iliac artery, which then gives femoral. So the blood supply to the lower limb will be affected. So even the internal iliac artery, the anterior division, will be ligated. Then if this doesn't work, then what do? Then we go for angiographic selective arterial embolization. So this will be done under angiography, and in most cases it is 90% effective, right, to resolve the issue. But when you have tried all of these procedures now, all these measures now, and none of it is actually working, then what do? It's simple. Then you have to opt. Then that is the time you start considering doing hysterectomy. In most cases, you need another consultant has to be there. Then the decision has to be made fast. You make a fast decision, and then you go for hysterectomy. So it is better to actually lose the uterus than to lose the patient. So that is how that is the stepwise measures you take if the cause is a tonic uterus, if that is the actual cause now of the postpartum hemorrhage. Okay, then for the other ones now, the uterus might have normal tone, but there is a bleeding. But now there is a bleeding, okay, due to a trauma to the genital tract. It could be due to laceration, episiotomy wound, or it can even be anything. There is hematoma, for example.
Retained product of conception.
It can be hematoma, vulvovaginal hematoma, or even the broad ligament hematoma, which is very rare. So whenever you've assessed the state of the uterus and you find that it is well contracted, so what you do is you have to explore, okay? You examine the genital tract for any area of bleeding, and then you suture it, and that will be the case here.
Okay, thank you very much for that illustrative and clear description of postpartum hemorrhage, the management, and everything. Now we are about to round up the whole thing. So we would like you to give us a brief conclusion of that will tie everything together about postpartum hemorrhage.
Okay, so in brief, postpartum hemorrhage is one of the most important emergencies, and it is the major cause of maternal death worldwide, in developed countries and in developing countries. Okay, so, and I think the most important thing here is the attitude of the attending officer. Okay, that is most important, because this situation is an emergency, is very chaotic. So your attitude will determine how well and the patient is actually treated. So in postpartum hemorrhage, quick recognition is important, and early institution of the appropriate therapy is also needed.
Okay. Thank you very much for being part of this today's episode.
Okay.
It's a wonderful and well informative episode. So here, bye for now. See you in the next episode.
All right, thank you.